Hello and welcome to Bite-sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of MRCP within the last 5 years and want to help you do the same. We are not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam or indeed medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is eosinophilic granulomatosis with polyangiitis, formerly known as Churg-Strauss disease. So what is eosinophilic granulomatosis with polyangiitis, or EGPA? This is an anchor-associated vasculitis, a term which you will be familiar with from our previous video. And this one is a triad of adult onset asthma with eosinophilia and vasculitis. It affects approximately 4 to 18 per 1 million of the population, depending on the studies and the population in which studies have been conducted. Tends to affect people around the ages of 30s going into their 50s, and there's really no ethnic, familial or gender predisposition. As we've said, it is an anchor or anti-neutrophil cytoplasmic antibody-driven vasculitis with granulomatous inflammation of the small to medium vessels. Now, the main symptoms in this particular disease is that you see adults with worsening asthma, which settles with high-dose steroids, and they can have fleeting pulmonary infiltrates. Kidneys are often involved, which can be anything from an interstitial nephritis to a frank glomerulonephritis. The nervous system can also be involved, so you may see a peripheral sensory neuropathy or a mononeuritis multiplex pattern. And finally, the skin can also be involved with cutaneous granulomata. Investigations are pretty much as that for granulomatosis with polyangiitis, the disease described in the previous video. And so it's really key with these patients to take a thorough history and examination. There's a wide differential diagnosis which includes severe infection, sepsis, because of the way that these patients can present, which is often in extremis. Bedside observations, therefore, are really crucial, so including blood pressure, pulse rate, respiratory rates, oxygen saturations, and the temperature. Urine dip should be performed looking for protein and blood. In terms of blood tests, and a full blood count should be undertaken, and critically you're looking for an eosinophilia in that. Renal function, liver function, and the inflammatory markers should also be performed. In terms of autoimmune serology, we would be looking for an anchor, but it's really important to do a full connective tissue disease screen and an ANA, as that does also fit within the differential diagnosis for this disease. And specifically, if we are diagnosing EGPA, we'll be looking for a P anchor in most cases, which is directed against MPO or myeloperoxidase. In terms of imaging, these patients do tend to undergo a wide range of imaging, but in the first instance, you'd be looking to do a chest x-ray, particularly in someone presenting with pulmonary manifestations. A CT tap can be undertaken as well, or a CT chest if the symptoms are very much within the chest area. And finally, a renal biopsy can be really helpful in clinching the diagnosis. In terms of treatment, with such a complex disease, often these patients are managed under a multidisciplinary team. So this would classically involve rheumatologists, renal physicians, pulmonary physicians, and anybody else in terms of specific organ involvement as well as allied health professionals. In terms of induction therapy, so this is to induce remission of disease when a person first presents, particularly with severe manifestations. We will be looking to give them high-dose steroids, usually intravenously, along with either cyclophosphamide or rituximab, and that really depends on the patient profile in terms of how young or old they are, also other comorbidities, and also in terms of how quickly we are looking to induce remission. In terms of maintenance therapy, this tends to be with a DMARD such as azathioprine or methotrexate. So let's do some questions. So the first question is, which of the following antibodies is associated with eosinophilic granulomatosis with polyangiitis? So our options are ANA, C-ANCA, P-ANCA, dsDNA or CCP antibodies. So really, we know already that this is going to be an ANCA-associated vasculitis, so it's a case of which one is the correct one. And as you will remember from an earlier slide, in this case it's P-ANCA. You'll remember from the previous video that C-ANCA is associated with GPA or granulomatosis with polyangiitis. Second question, which of the following is not a classic clinical feature of a patient presenting with EGPA? Non-resolving adult onset asthma, glomerulonephritis, mononeuritis multiplex, pleural effusion, cutaneous granulomata. Now, with such a severe disease, it can present in a whole myriad of ways. So you may actually end up seeing all of these things at some point in a patient with EGPA, but the least likely one is a pleural effusion. The other four are classic signs of this condition. So that's all for today. Thanks for listening to this episode of Bite-sized MRCP. If you like the sound of what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future, and we will see you in our next episode.